Today we'll be talking about, defining the treatment trajectory in the transplant-eligible population of myeloma. Again, I always like to start with some fun facts. Plasma cell disorders have been identified, since the antiquity of time. They have found, these kind of punched out lesions in the skull and even in mummified mummies on CTs, even in medieval times and in ancient Americas. So I brought this slide at one point. The very first randomized trial in myeloma that was published in Blood, if you believe it, was a treatment with urethane, which is a nitrogen mustard, and the placebo control received cherry-flavored Coca-Cola. So the results were the same. In fact, those who received nitrogen mustard had more deaths and died, and the control group enjoyed their cola. So we've moved along since then. Survival in myeloma has improved, and the curves continue to go up and up. And from the latest EBMT report, is starting to plateau as well. So we're talking about transplant-eligible population, and in the previous talk, we said the median age in myeloma in the Americas and in the West is 69, 70. In our age population, it's much younger population, 59. I have seen patients in their 20s diagnosed with myeloma, and as you can see, although we still have a peak in an older age, we still see quite the number of patients in the younger age group, which tells you is that for the most part, our patient population is a transplant-eligible population, and the numbers are different, but percentages around 60 to 80% of patients of myeloma in Saudi Arabia are transplant-eligible. So the myeloma therapy treatment paradigm is, as of now, categorized as transplant-eligible or transplant-ineligible. I believe this will change in the coming years to be more response-adapted and risk-adapted strategy. So with the transplant-eligible, you receive induction, transplant consolidation, maintenance, and you go through subsequent treatments with multiple relapses. And multiple relapses because, again, myeloma as of yet is an incurable disease. So, you go from one treatment to the next and you relapse from one treatment and ongoing. And as you move on with one treatment to the next, your response, duration and depth diminish and decreases as you move along. And this is the issue with myeloma. And this tells you that you probably need to start your best treatment early on. And now we have, many available new treatments that's at disposal. Panibinostat has been withdrawn. Belantamab is question mark because it is probably coming back based on the DREAM-7 and the DREAM-8 trial. But the question becomes what's the best combination in the front line? So how to approach those patients with transplant-eligible myeloma? Well, we knew through drugs initially that were good. So the theory was 3 better than 2. And the SWOG trial answered this. And with the addition of bortezomib to RD, we now have even 12-month survival by the addition of bortezomib for around 6 months. And then, however, myeloma treatment landscape is changing. Now we're trying to figure out ways to cure our patient rather than just controlling the disease. And we're giving more aggressive therapies early on, including quads. This resulted also in long-term therapies. Maintenance is now becoming a standard of care. Patients are always on some form of treatment. There is now greater emphasis on immunotherapy, as we spoke about early in the morning. And however, transplant still plays a key role. But the question becomes, will CAR-T replace transplant in the future? So if 3 better than 2, if VRD is better than RD, is 4 better than 3. So the hypothesis here is initially, well, let's take a look. Can we continue to do triplets and substitute carfilzomib for bortezomib? The endurance study pitted VRD against KRD and showed no difference in PFS. And I always thought of this as a lost opportunity because they never included high-risk cytogenetics patients. The second hypothesis was, well, let's do quads then. The first quad actually was adding the anti-SLAM F7, a drug that we never had in the Saudi market, elotuzumab. 2 trials looked into this, and both trials did not improve PFS with the quad therapy. Then came the third hypothesis, is adding anti-CD38 antibody, the daratumumab and isatuximab. And the first of these trials were the Cassiopeia trial, which is more of a European trial that had VTD pitted against Dara VTD. And each arm will get 4 cycles, transplant, consolidation of the same, but then a second randomization where some will get Dara until progression, which is every 2 months basically, and some will get observation and no maintenance. So across the board, whoever received Dara, whether in the beginning, at the end, continuous, had better response rates and better CRs, better MRD negativity compared to those in the red bars who had no Dara at all. So, and that also, reflected on the survival curves with progression-free improvement at 80 months follow-up. The Dara VTD median was 83 months compared to 52 months PFS, and there was also survival advantage at 72 months, 86% versus 77% favoring Dara VTD. Then came in the Griffin trial, which is a trial that's more in line with with our standard of care, looking at Dara VRD versus VRD, and again Dara VRD each getting 4 cycles, transplant, 2 cycles of consolidation of the same, and then maintenance. 200 patients were enrolled, and the primary endpoint was the stringent CR by the end of consolidation. Sure enough, end of consolidation, there were more VGPRs and more CRs in the Dara VRD arm, but the end of the clinical cutoff, CRs were almost 80% CR or better, compared to 60%, so 20 percentile points better in the Dara VRD arm. And in the PFS updated in the intention to treat population, the 4-year PFS rate, as you can see, 87% for Dara VRD and 70% for VRD, and the longer PFS yielded 55% reduction in the risk of death or progressive disease. However, there has been no overall survival difference between both arms. So some potential rebuttals for the Griffin trials. So, there are questions always being raised about, using Dara VRD upfront. Are we robbing patients of treatment options by using Dara early on? Many other options are available already or will be available in the second line. CAR-T has been approved. We just talked about it in the morning. And as well, belantamab is coming, which had an impressive PFS. Probably bispecific is going to be moving to the second line, so no. Won't Dara blunt, your vaccine's effectiveness, COVID, flu, Shingrix? True, but myeloma, we would argue, is probably a stronger predictor of vaccine non-responsiveness than anti-CD38 usage. The third question, won't the upfront Dara bankrupt the system? And this is the common theme here. Oh, we're using expensive medications upfront. But the truth is, actually, it's more cost-effective because fewer Dara doses are in induction. We're not talking about maintenance. We're just talking about the 4 cycles of induction. And instead, and in the relapse protocol, as you know, Dara is until progression. When the Condor trial, it was up to 2 years. So then came in the Perseus trial, again, a Dara VRD versus VRD, 700 patients enrolled in this population, 4 cycles of Dara VRD, 4 cycles of VRD, transplant, then 2 cycles of the same for each arm. Then Dara VRD moved on to Dara-Lin maintenance. And if you achieved MRD negativity, you dropped the Dara, but then you were able to go back to on Dara if you confirmed loss of CR or MRD resurgence. If you remained MRD positive, you continued on Dara-Lin. As for the VRD arm, they would take lenalidomide maintenance. The primary endpoint was the PFS with a multitude of secondary endpoints. And as you can see here, the overall sustained MRD negativity across the board, whether 10 to the power of -5 or 6, and more importantly, sustained MRD negativity, 64% compared to 30% at the Dara VRD at 12 months. more than double that with the addition of DARA. That translated to an improved PFS of around 84 months compared to 67%, sorry. So as you can see, the cumulative MRD negativity rates from the first dose continued to go up in both arms, but significantly much more in the DARA VRD arm at up to 36 months, 74% MRD negative compared to almost 47 months. Sorry, 47%. And also in high-risk disease, the benefit was still pronounced. So as you can see here, although the PFS advantage was not statistically that significant, there was a hazard ratio of 0.62. You can see even MRD negativity rate and sustained MRD negativity rate with the addition of DARA in the high-risk group was significantly better compared to the VRD arm. And when the first plot analysis, almost all patients benefited from the addition of DARA. Those older age group maybe not as much, but probably related to toxicity, infection, and the interruption of treatment. But for the most part, most patients had benefited, most subgroups had benefited from the addition of DARA. This is an interesting, very intense, protocol for high-risk myeloma population. So young patient population, transplant eligible, they enrolled 50 patients. So they received, so this is from the French group, the IFM, induction with DARA KRD, then they go for transplant, then consolidation, another DARA KRD 4 cycles, total of 10 cycles, and then another transplant afterwards, so tandem transplant, and then maintenance with DARA-R for 2 years. So the primary endpoint actually was feasibility, if they could have 70% of those patients receive a second transplant, and the results were impressive for this high-risk population patient. So if you could look at the response rate in this high-risk population, so these were high-risk cytogenetics, CR rates and stringent CR rates achieved in 81% of patients, 94% MRD negativity, and the PFS and overall survival data not reached. The 30-month PFS rate was around 80%. Again, high-risk population. So what about the addition of the other CD38 antibody, isatuximab? So the GMMG HD7 looked into this. The pitted, again, ISA VRD versus VRD, different kind of regimen with 3 times of 6-week cycles. Transplant, then a second randomization looking at maintenance with isatuximab len versus len for 3 years. And the primary endpoint was the MRD. Although the rates of CR was not much different in both groups, the rates of VGPR were better with the addition of isatuximab. And the MRD negativity with the addition of isatuximab was 15% points better at 50% versus 35% for VRD. The ISKIA trial looked also into, similar to that French group trial, the ISA KRD versus KRD in transplant-eligible myeloma. Again, patients younger than 70, 300 patients enrolled, looking ISA KRD versus KRD, 4 cycles, transplant, then consolidation of another 4 cycles, then light consolidation of ISA KRD or KRD, so once a month, ISA, carfilzomib every other week, lenalidomide reduced dose. Now they have also looked into MRD by NGS at different time points post-induction, post-transplant, and post-consolidation, as well as light consolidation. And the primary endpoint was MRD negativity by NGS. So post-consolidation MRD negativity, whether 10 to the power of -5 or -6, was better with the addition of ISA KRD. As you can see here, almost 20% points better. Post-consolidation MRD negativity by the high-risk cytogenetics, if you look here at the MRD negativity 10 to the power of -6 for those ultra-high-risk populations, so 2+ high-risk cytogenetics, 77% achieved MRD negativity compared to 27%. So significant improvement with the addition of the isatuximab. So now the guidelines tell us that, DARA VRD is the preferred regimen of choice at the category 1 NCCN. VRD is still recommended as category 1 in the other recommended regimen. And the MSMART latest iteration they recommend for quad therapy across the board for standard risk or high risk if it's feasible to give to your patient. So what about transplantation? So with the transplant, in the context of myeloma treatment, is it still relevant with all these novel therapies? Well, transplant has been a standard of care for so long, but now we're the era of modern therapy. We just saw the quad therapies. So now we're having IMiDs, PIs, and monoclonal antibodies, introduced in the upfront. So do we really still need transplant? And if you saw this, and we saw it also earlier, myeloma, transplant in myeloma, is still the highest indication of transplant based on the CIBMTR data, more than double that of the next indication, AML, which is mostly LO. And in fact, the transplant still, transplant numbers are still going up. It's not actually going down. So what does the data tell us on transplant in the era of novel therapy? So 2 trials looked into this recently, the French group IFM trial and the determination trial. So they looked at VRD, both of them VRD 8 cycles versus VRD 3 cycles, transplant, 2 cycles consolidation of VRD. The difference was in the lenalidomide maintenance, where the French group had len maintenance of 1 year, where the determination trial had lenalidomide until progression. And I like to call determination transplant versus no transplant, while the French group study early versus late. Because with the French group transplant, the control group, 80% of the patients ended up receiving transplant in the salvage second line, while in the determination, it just so happens only 35% had received it in the second line. So as you can see, significant improvement with transplant, median PFS in with transplant. With the determination was around 67 months compared to 46 months. That's a 2-year difference. So transplant really works, even till this day, even with novel therapy era. In the median progression with the IFM, it was a bit less, but remember, lenalidomide was until 1 year. So probably the addition of lenalidomide maintenance here had better control, until progression, had better control of the disease. However, this did not translate into an overall survival advantage. And if you look at cytogenetic risk, those with high-risk cytogenetics, there's a significant difference. So really try your best to get your patients into transplant if and whenever you can, because the median PFS of 55 months compared to 70 months in this patient population is really wide. But if you look, but more interestingly, if you have a patient truly standard risk, real standard risk cytogenetics, look at the median PFS with transplant, VRD transplant, 82 months. So you can give patients VRD transplant and len maintenance and make them progression-free without disease for 6-7 years. That's something. And so really think twice before not choosing to give transplant to your patient. So 2-year PFS advantage. What does that mean? So it means 2 additional years of oral lenalidomide compared to those who did not receive it, and then will continue to receive triplet combination therapy with DARA or azacitidine, dex, and so on. These are collection of all the trials that we talked about. This is the safety data in all the quad trials. Just as a general idea, you'll find more neutropenias in the quad therapies, and you'll find more signals of infection, but mostly grade 1, grade 2, and more pneumonias in the quad therapy arms and across all trials basically, but it's quite manageable for the most part. So should we transplant or not when minimal residual disease has been achieved in the initial therapy in myeloma? So we just talked about the IFM trial. If you see MRD negativity in these up to top 2 curves. So the one on the top is the MRD negative transplant, and this is MRD negative VRD no transplant. The other 2 here is those who did not achieve MRD negativity with either transplant or not. But what it tells you is achieving MRD negativity really makes you better regardless of what treatment. But even MRD negativity with transplant is better than MRD negativity without transplant, which means it's not just enough to achieve MRD negativity, but it's the quality of MRD negativity, and the sustainability of MRD negativity. This was less pronounced in the determination trial, where the top 2 curves is MRD negative transplant versus MRD negative non-transplanted group, and they are overlapping. which tells you what? That the MRD negativity power is as such that it can overcome the adversity that for those patients who did not receive transplant and achieved MRD negativity to have same results as those who had transplant. But don't be fooled by this curve, because you still have more MRD negativity in the transplant arm compared to the non-transplant arm. So you can't really rewind back time and say, well, I wish I transplanted the patient to get more MRD negativity. So can MRD negativity guide de-escalation and stoppage of therapy in some of those patients? So the master trial looked into this. They had a very aggressive induction with DARA-KRD, and then looking at, MRD at different time points, transplant, consolidation, another consolidation, and then MRD different time points. And if you have two MRD negativity, this is what was called the MRD sure, and you get a treatment-free observation and no further treatment. So the PFS and overall survival was impressive in those who had no high-risk cytogenetics or one high-risk cytogenetics. But those with ultra-high-risk disease had a drop in their PFS and overall survival. And as you can see, the 2-year PFS in the 90s here, but for the ultra-high-risk was around 58, and the survival at 2 years was 76%. But why is that? As you can see, most of these high risk and ultra high risk and standard risk achieved MRD sure almost in similar percentages. But then the sustainability was not there. So, those who had ultra high risk cytogenetics had 27% of them resurgence or recurrence of MRD, which explains the shorter PFS interval. So some trials are also now looking to use MRD to define the timing of transplant. So the advances schema looked into KRD and DKRD. They dropped VRD from the trial because they realized that it doesn't produce as much MRD negativity. 4 cycles. If you get a PR, you continue another 4 cycles. If not, you drop from the trial. If you get MRD negativity, then you go to maintenance. If you're MRD positive, then you go for transplant, then lenalidomide maintenance. So the other trial as well that looked into, so of course we're still waiting for the results, the MIDAS trial, which also looked into MRD to define timing of transplant. So this is a more complicated trial. They have ISA-KRD, 6 cycle, then harvest. If you are standard risk, and they categorize you as either high risk or standard risk. If you're standard risk, you get another randomization, another ISA-KRD for 6 cycles, followed by maintenance lenalidomide, or the transplant, and then 1 cycle of ISA-KRD, and then maintenance. In high-risk patients, what they thought, well, they looked at the master trial. I guess they thought, well, we need probably to transplant those patients. So they had transplant, either transplant or tandem transplant, and they all went eventually to receive isatuximab and iberdomide, which is a cell mode. Can CAR-T replace a transplant? This will be an interesting 2 trials from the CAR-T-2.5 and CAR-T-2.6. So CAR-T-2.5 is actually looking into replacing lenalidomide maintenance with compared to cell-to-cell then observation. But the CAR-T-2.6 is actually pitting head-to-head transplant versus cell-to-cell in the quad therapy era with DARA-VRD. I'm looking forward to see the outcome of this trial, and of course both of them will continue to lenalidomide 2 years. What about maintenance? Are we moving beyond single agent lenalidomide? So now we're looking at alternative single agent therapy, ixazomib, the tourmaline MM3, the PFS advantage was really only 5 months. We already saw DARA single agent in the Cassiopeia. But what about adding agents to lenalidomide? Bortezomib, carfilzomib, or anti-CD38 antibody. So the Emory University had looked into VRD as maintenance for patients where V is given still weekly, but lenalidomide is at 10 milligrams. And this is in the high-risk population. And in a univariate and multivariate analysis, it showed a significant improvement in the PFS and OS, but this is more of a retrospective study. What about adding carfilzomib in the maintenance setting? So the Forte trial looked into this. The Forte trial had 3 randomized arms, patients who had received KRD transplant, KRD 12 months, or carfilzomib, cyclo, dex, plus transplant. Then they had a second randomization, which is what we want to focus here, either carfilzomib len or len maintenance. So the response rates here, although had been similar. The MRD conversion rates from positive to negative in the KR arm was 46% compared to 60%, and that was significantly higher and statistically significant. And that also translated to a 10 percentage point PFS advantage at 3 years, as you can see here. So we already talked about the Cassiopeia, the second randomization part where patients were randomized to either DARA or observation. As you can see here from this PFS from the second observation, the longest PFS from all these 4 groups, DARA up front, DARA later, is the DARA throughout, where the 72-month PFS was around 60%, which is higher than all the other groups. And also the higher proportion of patients who had DARA or that did not go through a second-line therapy, the highest population of patients who went on to give second line of therapy are those who did not receive DARA, whether in the front line or in the maintenance phase. And even at PFS2, so PFS2 is the PFS, after you receive a subsequent line of therapy, it was still higher in those patients who received DARA upfront. So this was recently shown by the AMN group in Athens, Greece. These are PFS projections, were significantly longer with DARA VRD versus VRD across all 7 distribution in patients with transplant-eligible myeloma. So they looked at the best fit projection. So an estimate of 118 months longer PFS with using DARA, addition of DARA to VRD compared to VRD. Again, these are statistical projections, but it still it says something. This is, of course, sorry, I didn't mention from the previously talked about Perseus trial. This is the last trial I'm going to show, is the AURIGA study. So the AURIGA study is the study that looked into patients who were anti-CD38 naive, who achieved VGPR at induction, and they are post-transplant but continue to have be MRD positive. So these patients were randomized 1-to-1 to receive either Dara-Len or lenalidomide alone, and the primary endpoint was MRD negativity conversion rates. And as you can see here, the MRD negative conversion rates by 12 months across the board was superior with the addition of DARA. Those who had CR or better had 61% MRD negativity compared to 25% with LEN. And this was MRD negativity across all subgroups had benefited from the addition of DARA. And even with the doublet maintenance, looking at the conversion rates in those high-risk groups, if you can see here, the overall MRD negativity and conversion rate. So this one here is the standard risk, here both of them, and the other here is high risk. 3 minutes. Okay, so all the high-risk groups had 0, 0, 0, 0, 0, 0 with LEN maintenance. None of them had converted to MRD negativity. But with addition of DARA, as you can see, there has been an improvement of conversion, a significant improvement in the conversion of MRD negativity. However, it does not, this trial, translate to our current practice. We had already used DARA VRD upfront because this is for DARA naive patients in the induction therapy. Some studies that are ongoing right now, the MajesTEC-4 looking at teclistamab addition into the maintenance regimen, so 3 arms, teclistamab len, arm B lenalidomide, or arm C teclistamab alone. This is also again with elranatamab. Maintenance arm A is elranatamab versus lenalidomide in maintenance. Patient who remained MRD positive after induction and transplant. So this is my last slide, a conclusion on takeaways from the talk. So most patients should probably receive an induction therapy using quad therapy and anti-CD38 upfront. It is superior to triplets for induction and for the vast majority of patients. As we see, you always get your best response and the most depth and the longest PFS from the first front line. So use your biggest guns at your disposal and approved if possible. Transplant remains the standard of care for transplant-eligible patients. DARA plus LEN maintenance is emerging as the standard of care. Thank you very much.